Learn about the C-spine, the T-spine, and the L-spine. Hand me that right there, sir. Okay, first thing we're gonna do is gonna learn about this thing called the C-spine. Okay, so our patient comes in, we meet our patient. Hello, Miss Sydney, how are you doing? I see you are coming in for x-rays on your neck and your upper back. All right, Daniel, I'm gonna be your student tech worker today. All right, any chance being pregnant, blah, 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 nope. Okay, let's go ahead and have you undressed. I need everything from the waist off to include bra, shirt, necklaces, earrings, any tongue piercings that you might have. Also, by the way, ma'am, do you have any dentures or partials that can come out? Need those to come out too if you do have them. Here's a little cup, put your little false teeth in there. Okay, y'all heard everything that came off, everything from the waist up, shirt, bra, necklaces, earrings, oh yeah, and glasses, and anything in the mouth. Tongue rings, they can come out. Dentures and partials, if they can come out. False teeth.
So am I just that annoying patient that has the permanent retainer that does not come out?
Yeah, if you can.
Yeah, I was like, I got a nice bar that comes all the way across.
If it can't come out, I'm sorry.
It's glued.
All right, so then of course, bam, we shield the patient. All right. Now please don't do that on real day, but you know y'all gotta shield the patient. Okay, for those y'all that don't come back here and practice in this room a lot, first thing you do is take this table, move it all the way back so you can actually see your lines. Okay, please do that. Please do that. You got the video?
Yep.
Okay. So come on over here so we can show them what it look like. So that way they can see. Because if you don't move the table, you can't see these numbers. Okay. And then you'll end up putting them in the wrong spot, and then I'm gonna ding you. So we don't put the numbers in the wrong spot, because then I can't ding you. Okay. Because I'm not trying to trick you. I'm telling you what's going on. But if you do it wrong, I'm gonna ding you. And I'm gonna do it, put a nice smile on it. Why are you doing it? Because I told you what not to do right. So, all right. The correct cassette, 10 by 12. We're gonna go ahead and put this in here. Our name paperwork says an 8 by 10. We don't have any 8 by 10, so don't worry about that. Okay, so we're gonna angle this thing right here exactly how much?
15 to 20 degrees.
15 to 20 degrees, cephalic. All right, ready, Sydney? Put this right on the middle of the neck, also known as the level of C4. Please collimate appropriately. Right there. Move your patient over to the center just a little bit right there. Thank you, ma'am. Stand there. Slightly move back a little bit there. Right there, perfect. Get that marker. Let's line this up. Ouch. Yeah.
That sounds pretty.
So we put this marker on there. Once we do that, okay, ma'am, I'll give you some breathing instructions, all right? What I want you to do now is stop breathing, don't move, do not swallow. Beep. Breathe and relax. Now, what did I just say?
Stop breathing.
Don't breathe,
Don't
don't
swallow.
move,
Don't
don't swallow. Okay, those are the 3 things you must say.
I'm gonna need you to stop chewing it now.
Yeah. Don't breathe, don't move, don't swallow. The whole point of the swallowing is to stop any kind of motion in this area here, okay? Because motion and x-ray are mortal enemies, okay? So we don't want that. But that's how you best could do your APC spine. Now, do you know the reason why we angle this thing 15 degrees cephalic?
To get behind them.
Well, actually, your C-spines, when they stack, they sit at a slight angle. So the only way to see through them is to angle upwards.
Okay.
That's why. Okay. Because of
Because
how
of
this.
the lordotic curvature.
Yeah. Well, the lordotic is down here, but there's a slight one in here.
Yeah.
But when they sit like that, and so you're angling to go through them.
Okay.
Okay. All right. That's the easy one. Yes. Go ahead.
Was her chin supposed to be up?
Slightly up.
Okay.
Slightly.
Just slightly.
We
Okay.
don't want it
Just,
way up. No. We don't want that.
okay.
Just bring back that. Just.
So
Okay.
just kind of like looking straight.
Yeah. Straighten is the slight up. Slight. Now, words are very important. There's slight and then there's gross and whole lot. Gross and a whole lot go together. Slight mean a little bit. And we have to be very careful when we use these words and we read these words in test questions, particularly when y'all get into my class.
And it doesn't matter which marker we use, so long as we put it on the right side.
The correct side.
Correct
Side.
Yes.
Once
The
again,
right side.
words are important.
Yes. I realized it as soon as it came out of my mouth.
Yeah. You saw the facial outlet. All right, here we go. Okay, that's the easy one. Now, let's get a little harder. Next up, we're gonna do what's known as the open mouth or the odontoid. Okay, so the first thing we wanna do is adjust our collimation because the thing we're trying to see is very, very small. So I'm going to shrink this thing down this way. So I shrunk the collimation down like this. Beside the side, I'm gonna kind of basically leave it alone, okay? I'm gonna take this, I'm gonna put it directly over the patient's mouth, okay? They're gonna line this up over the patient's mouth. Now, there are two structures that we're going to be dealing with that are gonna be a problem. One is the back of the head. The second structure is the front teeth, or the top teeth. So the thing that you're trying to see sits in between these two things. So you have one in the back, you have one in the front. The thing we want to see is directly in the middle. So I'm going to have Sydney open her mouth really, really wide, and I'm going to put my finger on a thing called the mastoid tip, which is directly behind her ear. It's nice and hard. I'm going to draw an imaginary line from there to the bottom of her top teeth. That is called the occlusal plane. That line has to stay nice and perpendicular with this.
Okay.
Okay? Now, if I tilt Sydney's head up, the back of the skull is in the way. If I tilt her head down, the front teeth are in the way. If I bring it up just right, I can go through, I will see the odontoid process perfectly where it needs to be, okay? So make sure the patient's back is up against here, they're nice and rested, they open the mouth, and the head is straight. And what you're trying to do is find it. Use the laser as your level line. Okay, relax, Sydney. I borrow your pen. Sometimes you may have to use a pen to try to figure out if the patient heads move up or down, but you have to keep this in line with the top teeth. If the head moves, the pen moves. Okay? Questions on that one?
So is the CR going right below the teeth?
Yes, the CR is going directly in the center of the mouth.
Okay.
So we're not moving this, we're trying to tilt the head.
Okay.
Okay?
Because it looked like it was almost hitting her top
Yeah.
teeth.
It probably would, depending on, so like open your mouth back up really, really wide. Now watch. So it may hit the top just slightly, but
Okay.
the thing remember, what you're trying to see is about right here.
Right, right. Okay.
Now, what happens is, what makes this difficult, if someone cannot open their mouth very, very wide,
Yeah.
that becomes the problem. And now you're trying to manipulate the head in such a way where you can, because you only have about this much room to play with. So if y'all look at that picture very carefully, not so much this, look at this. What I want y'all to look at is, if you look at this part right here, you can see the teeth, but you can also see the back of the skull is that line right there. And here is C2, there is C1, is the top part of C2. So you want to see all of this. That's what you're looking at. But you got to get that mouth open nice and wide. Because if not, what will happen is this top portion up here called the tip will get blocked. And that's what we don't want to happen. Because if it gets blocked, then you got to do a bunch of additional shots. And there are ways to try to see around it. So one of the things, like with false teeth, we pull those out because false teeth, anything that's metal or very dense will appear as white, and it'll block
Right.
that.
Right.
Okay. The back of the head is also very dense. That's why you don't want the head to be tilted up, because you're going to get questions and it's going to be jacked up. It's going to ask you, okay, how do you correct this? Tilt the head down, tilt the head up, and you got to know which one you're looking at. Okay. Now, what I want everybody to do, come up here real quick. I'm gonna have everybody kind of press on Sydney's mastoid process real quick. So what's gonna happen, so when you get your patient in here, you're gonna do exactly like that. And really, the setup process should probably take you roughly about 30 seconds. Okay, that's how much time we really looking at. Because we don't want you perking, going back. No. It's gonna be up here. You're gonna put your hand right there. You're gonna hold. You're gonna hit your. Because what you're gonna do, you're gonna line all this stuff up first before you do any of that.
Yeah,
other
you
stuff.
line it up and the mouth is
Yes.
closed just when she's standing straight.
Exactly.
Okay.
So don't try to go in there, let me figure, nah, don't even do none of that nonsense. Okay. Now, here's the instructions on this one. Once we figure it out, we get what we like it. We have them open that mouth. There's some instructions here. Okay, so you open that mouth really, really wide. I want you to keep it open. I want you to start saying ah, and keep saying until I take the stop. Ah, beep. All right, breathe and relax. They gotta say that. You gotta do the ah thing.
Okay.
Yes, ma'am.
So on this it says they want collimated to 4x4. Did you just keep it wide
Now,
for the
I do
marker
that-
or
correct.
okay.
Correct. 4x4, yeah, right. Put it down. I ain't never done 4x4.
That's
It's on
why
there,
the
so I
book,
just had to ask,
This-
okay?
that's why the book works in theory.
Oh, the book does work. No, I mean, now, there's some things I do. This will give me the book. Yeah, yeah, you try to do it. So, can you do a 4x4 and still get a marker on there? Yeah, but you got to be very good. Nah, I mean, there's a way, and that was more so because that was more for a film thing. Digital makes it a little bit harder. All right, so far so good?
Mm-hmm.
All right, film. All right, let's turn the page. Okay, sorry. The obliques. There are two types of obliques. Posterior and anterior. And I need to make sure that we understand what those words mean. Okay. Now, what does the word posterior mean? Back. Anterior. Front side. So when it comes to the posterior and the anterior obliques, we are going, your reference point is the IR. Once again, your reference point is the IR. That means whatever side is touching. So if I'm doing posterior obliques, the back side is against that. Anterior, the front side. So for this right here, we're gonna start with the posterior because she's already in that position. Now, when it comes to the obliques, there's an SID issue. Now, your paperwork says it's gonna give you 3 different sets of numbers. It's gonna give you 40, it's gonna give you 60, and it's gonna give you 72. Now, I'm gonna give you the reason why all 3 exist. 40 can be done because it's probably the easiest on the tech. 72 is the one that should be used because it makes the image look the best. 60 is gonna be used depending upon the table that is available in the room and other
If you're
equipment.
doing a supine.
We're gonna be doing these with the patient sitting and or standing.
I mean, for the 60, like if that's the tube limit for
Yes.
when they're supine or something.
You keep saying supine, that means laying down.
Yeah, I know.
Patient won't be laying down.
He's
But,
meaning to push the table back so that it can go down
Yeah.
far enough because you're gonna have an angle on it.
Yeah.
Okay. Oh, because there's the angle.
Yeah.
Gotcha. Okay.
Okay. So I know you see the patient laying down
Yeah.
in that picture right there.
I mean, I know that we're not doing it for the
Yeah.
tests, but I was just thinking like with how far you can reach it up, if 60 was the max for going up.
No, 60 is between here and here.
Okay.
Yeah. So that's going to depend upon if you got a room. Yeah. Okay. But I want you to like,
Yeah, yeah.
Yeah, because ain't nobody doing C-spines laying down no more unless they're coming in for a trauma, and even then you only go do what's known as a cross table.
Okay.
Because we got this wonderful thing called a CT machine now.
Yeah.
Yeah. Okay, so we can have our distance 72 set up. We got to do something with this also. We got to what?
Roll it.
Roll it.
Angle it.
Angle it. Yes.
Well, I said
Now
roll because of that.
we don't angle it. Now we know that we're doing the posteriors first. So which way are we gonna angle this thing?
Cephalic.
Cephalic. Okay, 15 to 20 degrees cephalic. All right. Now, do you know why we going cephalic first? Close your eyes. Blind you. Clear. All right. So why are we angling upwards?
For the angle of the
Correspond with the angle, yeah.
Of the what now? Correspond with the angle of what?
The intervertebral foramina.
Okay. So now the word foramen, what's the word mean?
Foramen.
It's the hole.
It's a hole. So there are two sets of holes on both sides of your neck. They open like this, okay? But they also angle downward. So this is my little hand technique. So like this and downward. So because they're downward, we're gonna be shooting up into them. Okay? Now, what we gotta do now is get everything lined up nice and pretty. Right up to the neck, which is about right there. Right. Okay. Just come forward in this a little bit. So here, we're gonna learn how to do Mr. Gardner's robot. Okay, so we're gonna teach our patients how to rotate. Okay, I have a very unique way that I teach my patients how to rotate. Okay, all right, man, we're gonna do some turning here. All right, I need you to turn your head, your body, and your feet all together in one fluid motion. I call that the robot. So we're gonna put our hands like this. We're gonna keep the head, the body, and the feet together, and we're gonna do this little number right here. Okay? All right, now what I'm gonna do, I'm gonna stand at this little point right here, which is exactly 45 degrees away from her. Okay, man, go ahead and turn towards me like I just turned. You go ahead and turn, right there. Now, what position is this patient in? RPO. So, right side, posterior, oblique. I have just turned her 45 degrees because these tiles have 90-degree angles. So if you stand at these little points here, they're 45 degrees. They line up. That's the easy way to do it. Okay, that way you ain't got to guesstimate, figure stuff out. Use what's available to you. Okay? Now, the key to this, head, body, feet, everything must turn together. That is the secret. If the head turns and the body turns, start over. It's wrong. Trust me. Because what's going to happen is those holes you're trying to see, some will be open and some will be closed. So everything must turn together. That's the secret to this. Okay? Now, once you get the patient the way you want them, we then going to do some marking. Now, Sydney, I'm going to have her move about a ½ inch that way. Right there. So, I got both markers. Right side of the patient, left side of the patient. Once again, right side of the patient, left side of the patient. Because I know my lefts from my rights. Left marker, boom. Right marker, boom. Please make sure we know our lefts from our rights.
Do we have to do both?
Now, no. Because Kelly asked a very important question. How should we mark this? This is where it's going to get real weird. That is something you're going to ask when you go to clinic.
You mark the side that's being shown.
That depends.
Based on the clinic, yeah.
That's why, because see, some places want you to shoot the side that's down. Some want you to show the foramen that's open. Now, in this particular regard, the right side is down. But the left foramen is the one that's being demonstrated because they sit like this. So right now, the right foramen is coming this way.
And the left is pointing straight.
The left one is pointing to there.
Right.
So, that's a clinic question, is one that I am not going to even remotely try to answer.
So we just mark whichever side we choose, so long as it's correct for testing.
For testing, yes.
Okay.
But that's why, hey, I put both of them to be on the safe side.
Okay.
Okay. Now, once I'm done with that one, bring your patient back to position up in the center. We repeat the exact same thing on this side. Have our patient turn, do this. Okay, take a small step backwards, right there. Beautiful. If anything, I probably need to bring my central ray slightly up to about right there, actually.
I was gonna ask that.
Yes.
It looks a lot lower than the pictures, but I know the pictures are not always
Yeah, it
correct
should be about
either.
right there. No, that's where it should be. Boom. All right. That is how we do our posterior obliques. What do you think?
That's gonna be fun.
That robot method is very interesting.
Yeah, the carpet.
Oh, I love teaching robots. The robot is amazing. The robot has saved me many, many times from having to do a bunch of unnecessary repeats.
Yeah.
Now, let's talk about those SIDs for a second. That's no, don't change the thing. Now, if y'all read right there in that bottom part, why don't you go ahead and read that out for me real quick, Virginia?
A 60 to 72 inch SID is recommended to reduce the magnification caused by the increased OID.
Okay, so between Sydney's shoulder and Sydney's neck is this distance.
Yeah.
That's why that tube is pulled back. Now, sometimes you may go to a place where my table can't lower like this one did. So if that's the case, let's just say the table was this high. I would then have to bring this thing in much closer. So depending upon who your patient is, if your patient is shorter or taller, you may not be able to get this.
Right.
If that's the case, you're going to bring this thing in.
So that's where the 60 comes in.
Yes. So you have a range.
And how do we measure that? When
You can't.
Oh,
But we'll know, as long as you beyond 40, we
Okay.
good.
we just
Between 40 and 72.
So we just move about a foot
Somewhere
down.
between
Yeah.
40 and
Yes.
72.
We just
Okay.
move about a foot down.
Yes.
Good, good.
But luckily for us, you know, these tables can go up and down. Let's just put it like this. This table couldn't always do that about 2 years ago. Yeah.
Got a new table.
Yes. Okay.
Okay, down level.
All right. So far so good?
Yes.
All right. Any questions on this before we go on to the other oblique? Sure. Okay. Excellent. All right. Now we're going to do the anterior obliques. Okay. Now, what we going to do with this thing first?
Level it back out.
Level it back out and then what?
And then angle it down.
Oh, that angle it down. Okay.
Got it.
All right, we're gonna do that. Okay, what we gonna do with our patient?
Turn
Have her turn and face
So
the
they-
board.
Oh, yes, absolutely. Turn and face the board. All right, now we're gonna do this thing called anterior oblique. Obliques. Uh-oh, we got a problem.
We did both
We
here
can't
first.
see the.
Well, let's see. Come a little forward there, Sydney. You know, it's only getting about right here, give or take. You need to get up a little bit higher. What we gonna do?
Have her sit down.
Have her sit down.
Oh, I see. I didn't realize it.
That was all
Yeah.
good.
No, that's not the one that Brianna's sitting on, no.
Okay.
This the one I need right here, because this is the stool action. Now, me and Sydney love stool.
In clinic, we don't use stools though.
Yes, we do.
Oh, really? Because Ms. Foreman
Foreman
literally
doesn't like
says,
stools
don't
'cause
use
your
rolling
patient will roll
stools because
away.
they go.
Well, rolling stools. You should use other stools that aren't
The other
rolling.
stools, but the stools that rotate, yeah, they may not necessarily have
because you
wheels.
can
No,
turn
just
her.
no wheels. Gotcha.
Yes.
It can just be a little scary if they.
Yeah.
Yeah. All right, so this, I'm gonna use the stool to do all the rotation and turning. Now, there's only one problem with doing that in this room and the other room.
The knees.
This.
Yeah.
Yeah, because her knees are gonna bang that. But I'm gonna show you a way kind of around it.
The new floating iron, like Bucky's are nice.
Yeah, but we ain't got all that.
Yeah.
You only gotta do this like on Friday, y'all.
We're not that fancy.
Okay.
Oh, I did, sorry.
Yes.
So when we did the open mouth, Foreman said to change it to crosswise.
You can.
Okay.
Mhm.
All right, because it literally doesn't say crosswise or lengthwise on the page.
I know.
Okay. Okay, sorry. We're-
All right,
we're
you ready?
The
totally-
paper also says 4x4 collimation, which means it wouldn't matter.
Right.
Okay. So here's the secret. So right now there's no robot in this one this time. Okay. So what we're gonna do? We're gonna tell our patient, okay, ma'am, sir. Once again, those same instructions do apply. I need the head, I need the body, I need the feet to all turn once again in one motion. But this time, we're gonna let the stool do all the real work. Okay? So they just sit on that and we turn the stool. Okay? All right, Sydney, I'm gonna go and turn you to the left here. Let the stool do all the work. Ready? And we're gonna turn, stop right there. Okay? Now I'm gonna slide you slightly forward. I want you to lean forward just a little bit, right there. Okay, perfect. Now let's go ahead and just line this up. Right there. right there is pretty much how you do an oblique. Right now, she's in a RAO, right anterior oblique. What we think? Okay. So when you shoot your first one, remove the markers. Okay, Cindy, go ahead and turn back facing forward. All right, the exact same thing. We're going to turn to the right this time. Okay, ma'am, let's go ahead and turn. Stop right there. Slide forward a little bit. Lean forward. Okay. All right, right there. Bring your chin just a little bit. One thing with the chin, make sure the chin, once again, get that slight elevation to it. Very, very slight. Right marker. Left marker. Boom. Hold still, don't move, don't breathe. Beep. Bitch. What we think? Okay. All right, thank you, Sydney. All right, done with the obliques. So right now, you've just seen both sets. You've seen the posterior and the anterior. On checkoff day, you're gonna get one of those two. So you won't get both, but you're gonna get left and right, but you're gonna get two posterior or two anteriors. Okay. All right.
Let me know if you need anything.
Okay. Next up, we have what's known as our lateral. Lateral is pretty easy. I always tell this funny story about this one student some years back. He had a struggle with this because he couldn't get his patient to turn, and I was his patient.
Face the wall.
Yes, turn face the wall. Okay.
Please, thank you, Cindy.
Yeah. Now, if you got a really, really tall patient, you know, somebody who's probably like over 6'2", they got to sit down because good luck you trying to.
I could just see you taking an X-ray on my husband. Yeah. He's 6'8".
Yeah, he ain't gonna.
And on her tiptoes.
Well, that's the case.
We
Use the
had
thing
one
that he's
that
sitting
that
on.
was the
Yeah.
case.
Yeah, the thing that he's sitting on right there. You
Step stool, yeah.
Step stool. That's for you, so you can get up there and. Okay, because we got some short folks. What's tall patient you've done so far? Have you had to use step stool?
I get some now.
Okay.
She said it was comfy though.
She was comfy. I'm chilling. I'm relaxing. Yeah, I know. All right. So for this right here, we're gonna aim back with the middle of the neck, which is right around C4. All right, Cindy, go ahead and turn and face that wall, please. Up against that board there. Excellent day. Right about there. Okay. You're gonna mark for this one. Try to aim around here in the front area. It's a little easier. All right.
Anterior.
The key thing here for this one is to keep your patient's shoulders depressed and make sure your patient is staying nice and straight. We don't want any level of rotation, okay? Don't want the head tilted back too far. No, head tilted. No, we call those flexion extension beats. Those are done on purpose. You'll learn that in clinic, but nice and straight. Don't want the head tilted that way. No, that way. No, nice and straight once again. Now, in certain cases, you will probably give your patient some sandbags. Okay, when you give these to the patient, you want the shoulders to depress all the way down. No, no He-Man or She-Ra today.
It's not shoulder shrugs.
Yeah, no shoulder shrugs, okay? Okay. And right here, stop breathing, don't move. It's actually probably best to kind of breathe all the way out because it kind of relaxes. Okay.
Yeah, so
That
deep
way-
breath in, blow it out, hold it out.
Yep.
Don't breathe, don't move.
Yep. Okay, questions else on this one?
Turn and face the wall.
Yes. Straight?
Yes.
Too easy. All right, 2 more to go and we're done.
Well, does it matter if you tell her to turn and face the wall or tell her to turn and face you if you're standing on the side of her?
We always do left laterals.
Left laterals.
Left laterals.
Got it.
You do a right lateral, we're gonna ding you. We're gonna say it's wrong.
Magnification.
So face the wall. Okay,
The last 2 are actually the easiest. So on eval, they start with the T-spine first. Okay, first thing I'm gonna do, bring this bad boy in 40 inches. Yes, I'll explain that in a little bit. So you ready here?
Well, I was like, what is this?
Oh, much more, yeah. Because there's something, it's actually a science thing that I have to talk about. That it takes me a minute for everybody to kind of figure out what it means. See, they know what it means, though, don't you? Yes, yes. All right.
You won't understand it right now.
Yeah.
Do you want to do your collimation first?
Yeah, let me thank you, man. Thank you. Okay. All right, so there's a couple things with this one right here. There's a lot of extra reading in there, but the bottom line is, it's about the collimation for a second. Start with this part, read that out loud for me.
You use a 14 by 17 lengthwise bucky in the wall bucky,
Okay.
Place the upper border of the IR approximately 1.5 to 2 inches above the shoulder.
Okay, so come on over here, Sydney, real quick. So that first part says the upper border, which is this.
Yeah.
I'm placing that 1.5 inches above her shoulder, which is about right here. Yeah. That's good. Now I'm gonna line these two things up with each other. Okay. Now jump down to the next section.
All right, perpendicular to T7, approximately halfway between the jugular notch and xiphoid process.
Stop right there. Okay, so her jugular notch is about right here. Sydney, go and touch the xiphoid process. Is it in between those two locations?
Yeah.
Yes. Okay, next.
The exposure field should be collimated to 10 by 17.
Ah, okay. Step to the side for a hot second. So, how wide do you think your T-spine is from side to side?
A few inches.
About 3-4 inches.
About like that. So we're gonna give us a little bit more on each side. So I'm gonna column. So it's about. So realistically, your spine is probably about like that.
Yeah.
But we're gonna collimate to about right here. Okay.
Is that like 7?
That's 7, maybe about 8.
That's what the book says.
Yeah.
7.
So now what we're doing
I'm sure.
is we're kind of doing two things. We're making sure that we can see the anatomy, but we're also making sure we can place the marker on here as well. Now, I've already lined this thing up the way that I normally would do. Now, I'm gonna do something that I told you guys not to do.
Put it in the soft tissue? Or put it on the IR?
Yes, I am.
No.
No, I'm gonna put it right in.
Oh. I was like, don't do that.
But I always tell you to put the marker on last.
Oh, yeah.
Yes. So, well, I'm not putting it on first, but right in the middle. Now I'm gonna bring the patient back and put her right there. And what I need to make sure that she's centered, move a little bit to that way, right there, perfect. Good. Now, can you place markers inside of soft tissue? The answer is yes. How the exact wording is, do not put the marker in the essential anatomy.
Yeah.
Get that. Sorry, I gotta talk to the camera for emphasis, okay? Because I realize people they only remember the entertaining bits. So, this right here is not considered essential anatomy. Now, if I put it directly behind her daggone neck, that'd be essential anatomy. Don't do that. All right, so once I get it right where I want it, it's collimated properly. Once again, patient is shielded. Okay. We're gonna walk out, man. I'm gonna give you some set of breathing instructions. I want you to take a deep breath in, blow that breath all the way out. Hold that breath out. Don't breathe, don't move. Beep. Breathe and relax, please. Now, did everybody catch that? Breath in, blow the breath out. Hold the breath out. Don't breathe, don't move. Okay, the reason we're trying to get the air out of the lung and we're trying to move the diaphragm. So by blowing the breath out and holding it out, we keep the diaphragm up. Okay? That's it on that one. What do you think? Cool? Too easy?
Yeah, it's pretty simple.
All right. So, like I said, T-spine is the easiest thing you learn today. All right, ready for the lateral?
Yes.
Okay. We pop this on now here, turn this. Now guess what? My patient has not grown or shrunken. So I guess what I don't have to do.
So turn face the wall.
I ain't gotta move in this thing here. Only thing I'm gonna do is actually open my column, make sure just a little bit that way. Just a little bit. All right, man, go ahead once again, turn and face that wall right there again for me. Okay. Now, we're gonna take the hands, place them up, do them just like this. There you go, do the I Dream of Genie pose. Now, how do we find out where the T-spine is supposed to go? You have this thing called the coronal plane. Divide your body into front and back halves, right? What you're gonna do is when you divide the body into those halves, your T-spine lies behind your coronal plane a little bit, okay? So divide the body in half, have the patient move forward, move forward, move forward, stop right there, okay. Come back, just, and I'm using my hand as a guide to where I want the patient to go. I got a little bit of light field back here in the back, but that's exactly where her spine is gonna be. Now, go and relax for a minute, Sydney. I'm gonna show you where your marking spots are. Move forward.
Oh, sorry.
Okay, you ready? You mark here, here, and sometimes here. This is a no-go zone. Do not mark here, okay? Here, here. Those are your so this is primary number 1, primary number 2. That's the backup. But these are your 2 primary go zones. Do not mark over here. You mark over there,
Points on.
yeah. Your mark is in the anatomy. Because here's the deal. Your spine starts like this. It's gonna kind of curve back and then go straight down. Okay? So right now, you know these 2 areas, you are safe. Use them. Okay? So, no-go zone. Got that? Because somebody gonna forget. I already know. So send this video to the class, because I already know somebody gonna forget. Well, Mr. Good. Once again, look me dead in my eye. What did I just say? So I dare somebody to try me on this one. I dare. Okay, ready, Sydney? All right, so if I forget here real quick, hands out. Make sure your patient's staying nice and straight. Now, do me a favor, Sydney, bend your left knee for a second. That right there, that's a no-go. Your patient do this, stop that right there immediately, okay? Because their body is slanted. No, legs up, nice and straight. Okay, that's what we want, understand? Okay. Move forward just slightly, a little bit, move. Right about there, okay. All right, once again, same instructions on breathing. Take a breath in, blow it all the way out, hold it out, don't breathe, don't move. Beep. All right, breathe and relax, man, we're all done. Now, I'm gonna contradict myself here real quick. What SID did we just use for this lateral? 40. Now, if you read your book, it will say to improve image quality, do an SID of 48 inches. Okay, now that is something that should actually be done in the real world. Unfortunately, no one reads. But you're not gonna do that, are you? Because you're my students and you're gonna read. So that way when that test question comes around at some point in time, you're out there in clinic one of these days, hey, you're gonna pull that book out. This says 48. Now you're not gonna go up there and tell the text, hey, no, but you're at least gonna inform, enlighten. Hey, 48 may look better. Okay. All right, that's it. All done.